我叫陈映如，我在费城来，从费城来。我在美国出生的，所以国语讲的不好，所以用英文讲好不好？我慢慢讲，有问题的时候你告诉我。我今天讲那个 extended recovery after total knee。我在 Rothman 开刀 ，Rothman Institute 有好几个人，这个是我的人都有开刀。你们认识 Richard Rothman？ 他来中国好几次。So this is what I will talk about. 就会讲这些话，我慢慢讲。第一个是在 total knee 的时候用那个 preoperative medication， 所以还没开刀的时候，我们先给他们吃药。那个药是 Tylenol， 1000 milligrams, Lyrica, which is pregabalin, and then Celebrex。这个三个药再用嘴巴吃。好处是 oral medication gives you longer lasting pain relief. So it's better to give this because it lasts longer after surgery. Number 2, it reduces post-operative pain levels. So 病人不是那么痛。Number 3, it's different modalities of action. It works at different locations. And 4, it reduces the amount of narcotics afterwards. 所以他们吃的药比较少。We did a study on this and found that pregabalin patients actually do well and they don't have as much dizziness. 没有那么多头晕。The next thing is anesthesia, 麻醉. Which anesthesia do they use? So I'm going to try surveying the audience. Who uses general anesthesia after total knee? Anyone understand? General anesthesia. Who uses it? 第一个谁用那个麻醉？第二个，
我们玩麻醉的，
嗯，第三个，我用第三个，我们用第三个。All right. So general anesthesia. 好处是 there's very few contraindications. You can do it in most patients. 每个病人都可以拿这个。第二个 when the patient wakes up, you can perform a sensory exam. 他们起来的时候，他们有感觉。Number 3, you don't need training. At our hospital, the doctors don't always do the anesthesia. The nurses do the anesthesia too. What's bad is that afterwards you do anesthesia, you can have throat pain, 喉咙痛. It's a higher risk of infection. And the third, it's difficult to achieve relaxation. So you can't fully relax to do the surgery, which is a problem. Epidural anesthesia, we used to do this, but we stopped doing it. It's good because you don't have the throat pain, but you have a reduced risk of infection, and you can get full relaxation. What's bad is you need specialized training. You can't use it in patients with thin blood, and the last is you can't use prolonged anesthesia. We had a study where we looked at Duramor, which is a specific type of medication, and it had higher complications in patients, mostly with their heart. So we don't use Duramorph anymore. Spinal anesthesia. It's also good for the same reason epidural is good. No throat pain, decreased risk of infection, you can fully relax the patient, and there's less anesthesia time. What's bad is you need the specialized training, so you need someone to put the catheter in. You can't use it if patients have thin blood. What we use is 15 milligrams of 0.5% bupivacaine in the injection, and that gets you numb from the waist down. So 坏处是没有感觉，可是好处是 fully relaxed. What else do we do to make pain better after surgery? We use injectable medications, and I'll show you which type we use. And sometimes we use a catheter. So the injectable medication is on the right, and the catheter is on the left. So what do we put in our intra-articular injection? There's different versions. Number 1 is bupivacaine with epinephrine and ketorolac. Number 2 is bupivacaine without epinephrine and ketorolac. And the third is Exparel. If you put in epinephrine, do not inject close to the skin because it can cause death to the skin, which is a problem. What's the difference? Bupivacaine is cheap, Exparel is expensive. They are good for all other reasons. They can improve pain, decrease narcotic consumption, very easy to give, and there's no catheters. The study at our institution, at Rothman Institute, showed no difference between bupivacaine and Exparel. Other studies have demonstrated that Exparel is better, but normally Exparel funds the study. So the company pays money for it. This implant may do better. That's not what we're looking for. We were looking for something that's effective in patients. An intra-articular catheter is an OMQ pump that we use. There's other different versions out there. You can use it with 300 milliliters of 0.5% bupivacaine. No epinephrine in this one at all. It gives good pain relief, but the patients have a catheter sticking out of their leg afterwards, so that they carry around a pole, which is not always ideal for patients. We do types of blocks here. Sciatic nerve block, femoral nerve block, adductor canal block are the different blocks. We use ropivacaine. It's different than bupivacaine. It's safer around nerves. You can also use a catheter, which keeps medication for a long time, or a single shot, which is just one time. So sciatic nerve block, what's it good for? Sciatic nerve goes in the back. It gives relief to the back of the knee, which is good. The bad part is it must be used in combination with other blocks to give relief to the front, and it can result in foot drop. So the foot can drop if you block the sciatic nerve, the perineal version. Femoral nerve block, it gives you good or better pain relief than adductor canal block. The bad part is it makes your quadriceps weak. So the muscle here in the front gets weak from the femoral nerve block. Because of that, patients can fall. And sometimes we have to put a knee immobilizer around the patient so they don't fall. The problem is if you put the knee immobilizer on, patients don't bend their knee, so they don't do range of motion afterwards. Adductor canal block. Do you have adductor canal block here? Does anyone have it? Adductor canal? You need special anesthesia team to do that. It's a very good block. It blocks right in the spot that's located there. The good thing, patients can walk. 他们可以走路 and 没有痛 but it still has some more pain. So 还在一点点痛. So that's during surgery. After surgery, what do? We give medication by mouth. 要吃的药最好. So Tylenol, Lyrica, and Celebrex are what we use in combination. You can see the order at the bottom here. This is how much we give. 650, 75, and 200. If you have a sulfa allergy, we give naproxen instead of Celebrex. We also give IV. IV we give ketorolac instead. What other pain medications do we give by mouth? We give Ultram for mild pain. We give oxycodone for higher pain, and then more oxycodone for even more pain. What we don't use PCA. Who here uses PCA? Can you translate PCA? Not PCA 吗 ？PCA 什么？听不到。啊，你去讲吗？PCA 是打药的不方便。那个病人睡觉的时候要打药，没办法打药，所以要起床。所以我们不用了。No morphine, no dilaudid, and we don't use long-acting medication. We use tranexamic acid. Tranexamic acid, the benefit, it decreases blood loss. We don't use drains after surgery. In primary total joints, no drains. For tourniquet, it's good because you can see it better. The downside is patients have more pain, 比较痛. So, when we said if there's a calcified artery here, we don't use a tourniquet afterwards. The problem with tourniquet, it can have thigh pain, the patella contract and you can have weakness afterwards. So how do you close your wounds? Who uses sutures when you close the wound? 关的时候你用什么？ Suture or staple? Staple. 大部分用 staple 吗？比较快一点。可是我们病人不喜欢看这个，他说哦很难看，他们又叫那个 suture， 所以我们用 suture。这个是 continuous passive motion device。你们有些人有用吗？有没有人有用的？我们也没用，因为第一个很贵，第二个人在用这个剂的时候没办法走路，手不要再起床，走路那最好。And then finally， 不要英文讲 ，perineal palsy， 那个脚是用外的时候 ，you can get palsy， 是那个脚掉下去，很不好。So after you do surgery， 开完刀的时候要马上走路。So 我们请那个 physical therapist 拿病人马上走路。We start on the day of surgery once the anesthesia wears off. On the bedside, these are the exercises they do. We have them do exercises in the bed. 那他们马上运动，那最好也没有人帮助他们，他们自己会运动。我们给他们这个在床上，他们会运动。他们回家的时候，他们要自己走路，那是最好的运动。他们有2-3天，很短时间，你们比较长一点，对不对 ？So 我们请人去外面做那个 physical therapy， 那最好。我们要做那个 video physical therapy， 用电脑，他们可以学运动，做这些运动比较好一点，比较便宜多了。So in the hospital 1 to 3 days， 1天到3天他们在医院，回到家那最好。第二个是 inpatient rehab， 第三个是 skilled nursing facilities， 都写下。So the problem， 他们有 higher rates of 比较多感染。But 好处是有人照顾他们 ，so 那不要回到家的时候有可以别人照顾他们。So the whole point is to give medication before surgery. 你还没开刀的时候，你开始吃药，那最好。第二个用 spinal anesthesia. 3 intra-articular injection into the knee to decrease pain. You want to limit the pumps because patients are unable to do it. 4, use Tylenol or acetaminophen with ketorolac and celecoxib. Use tranexamic acid, it's very helpful. Don't use drains or continuous passive motion. Don't perform immediate physical therapy. 还得马上走路 and then 送到家. If it's safe, do it within 1 to 3 days. 谢谢你。